Thanks, Wendy. Okay, so fortunately, Kim Workowski, who you met yesterday, and I had a chance to confer a little bit before we put together our talks, and I'm going to pick up where she left off. Remember when she was discussing the CDC SUV treatment guidelines yesterday, she focused mainly on gonorrhea, chlamydia, herpes, and so on. I'm going to discuss with you the CDC guidelines for the management of three major types of infectious vaginitis. And then beyond that, I'll tell you about some changes that have come up in the way that we classify and manage vulvar skin conditions, particularly the vulvar dermatoses. Right before I came here, I was at the biennial meeting of the ASCCT, the American Society for Colposcopy and Cervical Pathology, which was in San Francisco, and picked up a few things about vulvar skin that I'm going to be able to tell you about this morning in this talk. So, as yesterday, I don't have any conflicts of interest. And I'll remind you that when we see women who have complaints of vulvovaginal irritation, itching, burning, other sorts of symptoms, obviously the first thing we go to is the possibility of infection. So the three types of vaginal infections that we're discussing are vaginal trichomoniasis, which nowadays is abbreviated VT, bacterial vaginosis, which is BV, and vulvovaginal candidiasis, which is VVC. But just because it itches or is irritative doesn't necessarily mean that it is one of the classic three types of vaginitis. A woman can also have a number of different types of fungal vulvitis on her vulvar skin, Candida being the most common, but tinea is a possibility as well. It can be a contact dermatitis, what we call a vulvar dermatosis, which, as you'll see in a moment, are lichen sclerosis, lichen planus, and one called lichen simplex chronicus, the three lichens. And then if we have time, because we're already starting a little late, I'll show you a few photographs of the lesions that go along with a pre-invasive condition of the vulva, which is called vulvar intraepithelial neoplasia, or VIN. So, to pick up on the CDC STD treatment guidelines, let's go to trichomoniasis and talk about how the guidelines changed in 2010 in comparison to what we had seen in 2006 and earlier versions. The first has to do with whether any woman should be routinely screened for trichomoniasis. In the past, we've always said that trich doesn't have a whole lot of morbidity that goes along with it. So we're just going to do diagnostic tests in women who are having a workup for a vaginal discharge or vaginal irritation, but we're not going to screen certain groups of people routinely, even if they're asymptomatic. CDC changed that a little bit this time around, and they say that women who are HIV positive should be screened for trichomoniasis annually. The main reason for that is that if you're HIV positive and you have trich, there's data from Africa that says you're more likely to transmit your HIV infection horizontally to an uninfected person. Maybe something that has to do with all the inflammation going on in the vagina. And then there's also at least some curiosity about whether if you're HIV infected and you have trich, that it may have some impact on your HIV disease. That one is much less clear than the issue about horizontal transmission. They also added sort of a lukewarm statement that for women who are at increased risk for acquiring other sexually transmitted infections, that we might routinely screen them for trichomoniasis as well. So for a woman who has a new sex partner or multiple sex partners, a history of STIs recently, inconsistently use condoms, they're sex workers, they're IV drug users, that in that circumstance to consider routine trichomoniasis screening as well. As a guideline junkie, I really dislike this idea of wishy-washy guidelines. Look, we either do it or we don't. And this whole idea of considering doing it, I thought was a little tepid. But I think we're kind of moving in that direction, at least for people who are at increased risk of being infected. Second is that there are some new tests out for trichomoniasis. The most important is a rapid antigen test that is very similar to the nucleic acid amplification test that we do for gonorrhea and chlamydia. So it's called the Aptima TMA analyte-specific reagent, and you will start to see that in the laboratory slips of the labs that you work with, that they'll offer you this very sensitive, although somewhat expensive test for being able to make the diagnosis of trichomoniasis. And then in the CDC guidelines, they also go into some detail about the idea that if we suspect that a woman has trichomoniasis, but we don't see the motility on the slide, that we should do one of these backup tests. Or if a woman has the finding of trichomonads on a cervical cytology smear, and she is a person who you wouldn't expect to have it, or you don't see very much of trich in your patient population, then before you treat her, it would be a good idea to do a confirmatory test. On the other hand, if in your patient population you see a fair number of women with trichomoniasis, and it shows up on Pap smear, that does have a better positive predictive value, and in that case, it's best just to go ahead and treat it. They also say that when a woman's been treated for trich, that we should consider retesting her to make sure she's not reinfected 3 months later, the way we do with gonorrhea and with gonorrhea and chlamydia treatment currently. So this slide basically goes through the variety of tests that we have available to evaluate trich. The Aptima TMA is the one that I just told you, which is highly sensitive and specific. There's a culture for trich, which is called a Diamond's media, which drops off a little bit in sensitivity, but is highly specific. And then there are 2 point-of-care tests that are available to do in your office. One's called the Affirm VP3, and it actually tests for 3 different organisms, so for trich, Candida, and BV. And then there's also a point-of-care test that you can do in about 10 minutes in your office, which is called the OSOM Rapid Trich Test, which is reasonable sensitivity and very high specificity. It costs about $9 a test and is becoming popular, again, not as a screening test, but as a confirmatory test. And then the saline suspension is listed as well. So what about changes in treatment guidelines? The recommended treatment for vaginal trichomoniasis is metronidazole, 2 grams as a single dose. We've had that one for 30 years. But now elevated to recommended status is tinidazole, 2 grams as a single dose. And the advantage of tinidazole is the fact that it's a little more effective than metronidazole is, and it's in women who use it, women and men who use it, are a little less likely to have side effects. The trouble is that it's far more expensive than generic metronidazole. So in a case where you're very cost sensitive, it would make more sense to use metronidazole. On the other hand, if this is a person who's had side effects from metronidazole in the past, or a person who's had a metronidazole failure, then tinidazole is definitely worth the investment in that circumstance. They still list an alternative regimen of metronidazole for 7 days, although they say that that is the preferred regimen for women who are HIV infected. They also point out that if we see vaginal trichomoniasis in a pregnant woman, we should treat her, and that metronidazole, being FDA pregnancy category B, is safe in all trimesters. So there is no reason not to treat a woman in her first trimester of pregnancy who has trich and is symptomatic from it, because we're worried about metronidazole being teratogenic. It clearly is not in humans, and not only has the stamp of approval of the FDA, but now the CDC as well. And of course, we always treat sex partners within the last 60 days of any person we treat for vaginal trichomoniasis. Now, they also go into some detail about the fact that the CDC is getting reports more and more often of relatively metronidazole-resistant strains of trichomoniasis. There has not been a super strain of trich yet, which seems to be totally resistant to imidazoles, but they're becoming more and more relatively resistant. So there is an algorithm contained in the CDC guidelines about what to do for women who have a failure of first-line therapy. Now, the most common reason for failing treatment for vaginal trichomoniasis is not because you have a superbug, it's because your partner wasn't treated and you've gotten reinfected. So they recommend that if a person fails the first therapy, to either use tinidazole as a 2-gram single dose or metronidazole twice a day for a week. But if a person fails that, then they get a higher dose of metronidazole for 3 to 5 days. If they fail that, then they get oral tinidazole and vaginal tinidazole at the same time. And if they fail that, CDC literally gives you their phone number. And it's on the slide. They want you to call, because what they will do is to send out to you a culture media where you can take a swab of the woman's vaginal discharge, send it to them so that they can do very high-tech sensitivity testing and find out whether or not this is actually the bug, which will be completely metronidazole resistant. Okay, let's go to the next type of vaginitis, which is bacterial vaginosis. First, I want to remind you that it was probably inaccurate to some degree for me to even refer to it as a vaginitis. A vaginosis refers to the fact that it is a vaginal condition which is due to an overgrowth of certain types of bacteria in the vagina and a loss of the normal flora of the vagina. However, it's not particularly inflammatory, so most women who have BV don't have a lot of itching, burning, or irritative symptoms. The main thing that's going on with BV is an overgrowth of bacteria that are normally in low levels in the vagina. Gardnerella vaginalis and a variety of anaerobes may increase 100-fold to 1,000-fold in terms of their concentration in the vagina. And then there are a few other pathogens that can go along with BV, like Mobiluncus and some of the mycoplasma. But that's only half the story. The other half of the story is that women who have BV lose the normal hydrogen peroxide producing lactobacillus that live in the vagina. Many of us were taught that it's Lactobacillus acidophilus which normally populates the vagina. It turns out from Sharon Hillier's brilliant work that that's not true. There are other strains of lactobacillus like Lactobacillus crispatus and Lactobacillus jenseni, which are the most common strains of lactobacillus in the vagina. They're the ones that make hydrogen peroxide and protect women against infections by other pathogens. But it helps to confirm something that you heard yesterday about the fact that if you take the dairy version of yogurt and try to use that as a treatment of bacterial vaginosis or any other type of vaginitis, it doesn't work because it's the wrong type of lactobacillus. Acidophilus and vulgaricus can't stick to the vaginal epithelium and therefore they're not therapeutic. It's also worthwhile to remind you that more than half of women have Gardnerella vaginalis as part of their normal vaginal flora, but do not have the condition of bacterial vaginosis. And that's one of the reasons that women who are not pregnant, it is a useless waste of time to do a vaginal culturing sensitivity for bacteria. You may want to culture for Candida in the vagina, we'll come to that in a minute. You may need to culture for Trich in the vagina if your lab offers that. But there's never a reason to do a general culturing sensitivity of vaginal fluid in non-pregnant women. Of course, in pregnant women, we're looking for group B strep, but in non-pregnant women, virtually anything you find, including Gardnerella, is a normal part of the vaginal flora. And as you'll see, the finding of Gardnerella is not part of the diagnostic criteria for bacterial vaginosis. It's one of the problems with the BP3 test, is that when it looks for the BV component, it actually confirms the presence of Gardnerella. And that's not how we make the diagnosis because half of women have Gardnerella normally. Now, one of the debates that has occurred over time, Patty will probably also mention this, is about the sexual transmissibility of BV. 30 years ago, we thought it was sexually transmitted in the way that Trich or gonorrhea are transmitted. More recently, we have come to realize that in heterosexuals, it's associated with intercourse, but it's probably not transmitted by intercourse. It looks a little like a sexually transmitted infection because it's rare in virginal women. A risk factor for women is the more male sex partners you have, the more likely it is you get BV. And we know that you're protected if you use condoms to some degree. But there is no BV carrier state in men. Urologists have been looking for 20 years to find BV in men and haven't been able to find it. And we know from at least 5 studies that if you take women with BV and treat their male partners or not, that the recurrence rate in women is identical. It just doesn't help to treat male partners. So what do they mean by sexually associated? That it is associated with unprotected intercourse. And the best theory we have, again from Sharon Hillier, has to do with the fact that in women who have bacterial vaginosis, what seems to happen is when a woman has unprotected intercourse and there are sperm deposited in the vagina, that they have adherence to the normal epithelial cells that are in the vagina, as well as to the lactobacillus, and that the sperm ultimately are toxic to the normal lactobacillus, which means that their levels drop and the anaerobes are able to overgrow. So in heterosexuals, it's more associated with unprotected intercourse, but it's related to exposure to sperm. It's not related to exposure to any sort of pathogen. Now, the experience in women having sex with women is somewhat different. And Jeannie Marazzo up in Seattle has done a number of studies that have shown that among couples of women having sex with women, that there's a fairly high concordance rate that if one partner has BV, then her partner's also got about a 60 or 65% risk of having BV. There, because there may be transmission of vaginal fluid from one woman to her partner, with direct inoculation, that does seem to be associated with horizontal transmission. So in that circumstance, we think that it is more of a classic sexually transmitted infection than it is in heterosexuals. So how do you make the diagnosis? The classic way is through what are called the Amsel criteria. So a typical homogeneous white vaginal discharge, a positive whiff test, sniff test, odor test, they're all the same thing, and that is to say when you alkalinize the vaginal discharge with some potassium hydroxide, it has sort of a fishy or an ammonia-like odor. A pH of higher than 4.5 and clue cells on microscopy. I'll show you some of those in just a minute. There's another way of diagnosing BV, which are called the Spiegel criteria or the Nugent score, that we use primarily for research purposes and not so much for making a clinical diagnosis. So the appearance of BV looks just like a cup of homogenized milk that's been spilled into the vagina. It's quite homogeneous, it's white or slate gray, sometimes it's bubbly in the way that milk will be, and oftentimes it comes out of the introitus, and you'll see it on the labia and even on the perineum. This is a look at what clue cells look like, and the main thing to give them away, whatever, that's okay, oops, I have to go back, is that not only do the epithelial cells have the stipple cobblestone appearance that you can see, but if you look at the very bottom where it says ragged cell border over X, where you see the edge of these epithelial cells having a really ragged sort of geography to them. That's really what gives an epithelial cell away as being a clue cell, not so much all of the stippling on the clue cell itself. And if anything, more than 20% of all the epithelial cells you see are clue cells, that qualifies as being clue cell positive. So this is a listing then of all the different tests that we have for bacterial vaginosis. Nugent score is actually the best, but it's fairly labor intensive. We have the Affirm DP3 as a point of care test. Another point of care test, which is called the OSOM BB Blue, that runs about $10 or so. Not quite as accurate as the rapid trick, but a very reasonable test to have in your office as a confirmatory test. And then the Amsel's criteria, which most of us continue to use as long as they have a microscope. And your clinicians are CLIA certified and clinician perform microscopy so that you can actually be able to look for clue cells. Now, who should be screened or otherwise tested for bacterial vaginosis? The CDC does not recommend routinely screening for bacterial vaginosis either in pregnant or non-pregnant women. If we're doing diagnostic testing for a woman who has a vaginal discharge, take a sample of her discharge to evaluate it under the microscope, do the amnion test or whiff test to look for the change in odor with the application of potassium hydroxide. And hopefully you have some pH paper available in your office to be able to check vaginal pH. But more and more offices don't have microscopes. So if microscopy is not available, or if you do microscopy and you're just not sure whether or not those are clue cells, then you have the point of care test that I mentioned to you a moment ago. Now what about a cervical cytology or pap smear that comes back and it reports no evidence of dysplasia, but shift in vaginal flora consistent with bacterial vaginosis, which is still part of the Bethesda system for how pap smear results are reported. That finding actually has very poor correlation with the diagnosis of bacterial vaginosis. So most experts no longer make any link between that finding on pap smear and actually doing further diagnostic tests or even treating the patient. Many of us have just stopped even telling patients about that finding on pap smear, knowing that if she had symptomatic bacterial vaginosis, we would have noticed that on the day that we performed the pap smear. So finding this change in flora on pap smear is really not anything to worry about or even necessarily to offer a woman to work on. So the way that we treat bacterial vaginosis really hasn't changed much in regard to either using oral metronidazole, metronidazole vaginal gel, or clindamycin vaginal cream. But this time around in 2010, there are a number of regimens that include tinidazole for the treatment of bacterial vaginosis as well. So 2 grams once a day for 3 days, or 1 gram once a day for 5 days are considered to be acceptable alternative regimens for bacterial vaginosis. Now, one of the problems that you're likely to see are women who have recurrent BV. Somewhere around half of women who have a first episode of BV will have a recurrence, and about 20% have 3 or more recurrences in the next year. And patients don't like it, and oftentimes their partners have complaints about it as well because of the odor that goes along with bacterial vaginosis.
So the one evidence-based treatment for women who have recurrent bacterial vaginosis is to do a full initial therapy with one that I mentioned among the CDC recommendations. And then you can do a suppressive regimen with metronidazole vaginal gel. The way that that's done is twice a week. I tell my patients every Monday, every Thursday before you go to bed, one application of metronidazole vaginal gel. The study went for 3 months and then stopped. But women who really do this for 6 months or a year then should probably take a drug vacation and see whether or not they still need it. But it is a fairly effective and the only evidence-based approach that we have to suppressing recurrent bacterial vaginosis. There's also lots of buzz about using probiotics, but none of them have actually been shown to be effective in treating bacterial vaginosis or preventing recurrences. We should remind women not to douche in general, but especially if they have recurrent bacterial vaginosis, because that may actually make it worse in terms of recurrences. Use of condoms by male partners does seem to reduce recurrences. Patients should be reminded to clean their sex toys or to put condoms on their sex toys between uses, and also to avoid vaginal insertion of a finger or a penis after anal insertion, again because of the introduction of gut flora and anaerobes into the vaginal environment. All right, the third of the vaginal infections is vulvovaginal candidiasis. And the way that the CDC classifies this is as uncomplicated or complicated candidal infections. So an uncomplicated infection is a woman who has an occasional or infrequent outbreak. It's mild to moderate in severity. It's most likely due to Candida albicans rather than one of the other strains, and it occurs in a woman who's immune competent. That's 90% of the garden variety candidal vulvovaginitis that we see. Complicated vulvovaginitis is when a woman has it recurrently, or it's a particularly severe outbreak, and she may actually have an allergy to Candida, which makes it so itchy and irritating for her. Or if it's due to a non-albican species of Candida, or if she's immune compromised. So if she has uncontrolled diabetes, or is immune suppressed, or is pregnant, in those cases of candidiasis are more difficult to treat. Remember, the way that we have historically made the laboratory diagnosis of vulvovaginal candidiasis is with potassium hydroxide suspension. pH can be anything from the high 3s all the way up to 6 or 6.5. The amine test is negative. And if you need a confirmatory test, as I mentioned earlier, the VP3 does look for Candida as one of the 3 pathogens that evaluates as a point of care test in your office. Or you can order a candidal culture. And I want to emphasize that there's a difference between a candidal culture and a fungal culture. A fungal culture was for dermatophytes. They take 5 weeks to come back. They're relatively expensive, and sometimes they miss Candida. You're just looking for Candida albicans, for glabrata, for tropicalis, and some of the others. And for that, you order a candidal culture. That result should be back in somewhere between 4 and 7 days. And so you specifically want to order that and not a fungal culture. There's also a candidal PCR available in some labs. So there are a variety of drugs available to treat vaginal candidiasis, and I've summarized them for you in this table. They're available over the counter. And you know that many women who self-diagnose as having vulvovaginal candidiasis will just run down to the drugstore and pick up iconazole or fluconazole or one of the others over the counter, or there are other drugs that are available strictly by prescription. The bigger question is, should I prescribe to a patient one of the topical antifungal drugs, or should I offer her oral fluconazole as a single dose? And nationally, there's about a 50-50 split in either of those approaches. And the answer is it should always be up to the patient to decide. So if this is an uncomplicated case of vulvovaginal candidiasis, particularly if it's just strictly vaginal candidiasis, what you can say to her is that I can offer you a topical drug, which will give you very quick relief because it's so soothing, but you have to live with the topical medication for 3 days. It might be a little tricky or uncomfortable. On the other hand, I can give you an oral medication with a single dose of oral fluconazole, but its effect is not immediate. You may not start feeling relief from your itching until the next day. And most women are now so aware of these alternatives that they'll tell you when you've diagnosed candidiasis, I'd rather take an oral pill, or I'd rather use one of the topical medications. And if you use a topical medication, one of the 3-day regimens typically is fine. If the first course of treatment fails, then make sure that it's actually Candida and not some other infection that you missed. And nowadays, there's really no role for nystatin and candida and some of the old-fashioned antifungal drugs. Okay, so for people who have severe vulvovaginal candidiasis, the way we know that, as described by the CDC, is that these women will have lots of redness and evidence of scratching and fissuring on their vulva. It's more difficult to try to clear up that infection, so typically we use topical azole therapy for anywhere between a week or 2 weeks. Next is a person who is immune compromised because of the fact that, let's say she's HIV infected or has other reason for compromise of her immunity. Then again, the ideal treatment is either a topical imidazole for a full week or 2, or fluconazole can be used. The way that we do that is that a single dose of fluconazole lasts for 3 days. So she can be given fluconazole every 3 days for 3 tablets. So basically Monday, Thursday, the following Monday will be the full treatment in that circumstance. If she's pregnant, we try to avoid oral fluconazole and use topical azoles for a week or sometimes a little longer. Then for recurrent vulvovaginal candidiasis, which is defined as 4 or more episodes per year, most women don't have predisposing conditions that you've heard about, things like diabetes and HIV. But for women who have risk factors for those conditions, it would be a reasonable idea to check. Before you recommend to the woman that she use one of the suppressive therapies that I'll tell you in the next slide, it would probably be a good idea to do a candidal culture and confirm that that's actually what it is. Because very commonly women will come in and say, I just get these yeast infections over and over and over, and they're driving me nuts, and is there anything you can do to stop them? And before you do one of those suppressive regimens, unless you see Candida under the microscope, it would be a good idea to go ahead and culture it, not only to make sure that it's Candida, but also so you can speciate it. So what the CDC says about treating women who have recurrent vulvovaginal candidiasis is a wash-in therapy for a week or 2 with a topical drug or oral fluconazole every 72 hours for 3 doses. And then they list 5 or 6 different kinds of suppression regimens. The one that I want to mention that is most widely used is the one on the first line. That's fluconazole, usually 150 milligrams, used once or twice a week. And the way that most of us use this suppressive regimen is to treat the initial candidiasis, or treat candidiasis with a full course of therapy. Then go to twice a week therapy with fluconazole 150 milligrams. So again, I like the Monday, Thursday idea. And then if it's suppressed for, let's say, a month or 2, then she can titrate and go out to once a week. Many women are covered just by a single once a week fluconazole tablet. If they're not, then you've got to go back to the twice a week. Now that regimen was published up to 6 months, but many women use that over a period of years, and it's quite safe to be able to do that. So now what I want to do is switch gears, just tell you about a couple of the vulvar skin conditions, and then we'll take some questions after that. So far, when I talked about candidiasis, it was mostly vaginal candidiasis. When a woman has vulvar candidiasis, her vulva will be very itchy. The presentation is you see lots of redness, and classically women who have vulvar candidiasis will have satellite lesions. Sometimes you'll actually see a thrush sort of picture. You can usually tell what it is by looking at it, but if not, you can do a skin scraping and look at that under the microscope with potassium hydroxide and send it for a candidal culture. This is a patient of mine from San Francisco General who has been itching for a year, has been doing lots of scratching, and you can see how thickened her labia and the inside of her thigh is. The main reason I included it is to show you that outside of the main rash are these individual lesions. Those are the ones that are called satellite lesions. And whenever you see those small circles outside of the main rash, it virtually always goes along with having candidiasis, even for a baby that has a diaper rash. Here's another patient who has been scratching her vulva for an extensive period of time. It's quite thickened, white, but it does not have the satellite lesions associated with it. So how would we manage a woman who has particularly a long-standing vulvar candidiasis like that? The answer is with topical antifungal therapy, given for a week or 2. And for the women I showed you, it would probably be more in the direction of 2 weeks, or oral fluconazole, given as a first dose, repeated again in 72 hours, and then the 3rd time after that. But they also need some medium potency steroids to dial down some of that inflammation. So I would also use triamcinolone ointment. Ointments are always better on the vulva than creams because they stick better and they're more powerful. And you can use either TAC 0.1% or TAC 0.5%. But only until the inflammation is under control that you stop the triamcinolone and continue the antifungal drug for the full course of therapy. Now, the other kind of fungal infection that women can get is tinea cruris. So just like in your primary care practice, you see men who have jock itch, it's also possible for women to get that as well. So the presentation of that is asymmetrical lesions on the proximal inner thighs, rather. Usually it's a raised border with no satellite lesions. So here's a woman who has pretty classic tinea cruris, primarily here. But the even more classic presentation is this ring. You can see here it's exactly why tinea cruris was called ringworm in the past, with a raised edge that almost looks like a worm is burrowing around. And in that circumstance, if you were to do a scraping of the edge, you would see that it's filled with candida. So with tinea. So the treatment for that is to use one of the topical azoles, again for an extended period of time, for 10 to 14 days. Another drug which is out there is called terbinafine, the generic version, Lamictal and the trade name, given topically, again for a couple of weeks. If it's really severe, fluconazole can be used orally once a week for 2 to 4 weeks. And again, you want to treat the inflammatory part with triamcinolone 0.1% ointment, just for the first couple of days until the itching gets under control. I'm going to skip over intertrigo, but I'll just remind you that in this very same patient, she has a completely separate rash up here under her panties, which is sort of a dull red appearance to it, an area where she's had friction both from her panties and from her panty line. And that may be super infected with candida, different than the tinea cruris that she has in the other part of her genital skin. I am going to skip contact dermatitis, but I just want to let you know about a few of the other things that I've listed in the handout for you, and that is just to get to the vulvar dermatosis and to give you a visual, quick picture of the kinds of vulvar skin conditions that can cause lots of itching, but are not particularly, that are not infectious. So we have an old-fashioned version of how we classify these conditions. They're either atrophic, in which case we call it lichen sclerosis, hyperplastic, in which case it's called squamous cell hyperplasia, but colloquially we refer to it as LSC, or lichen simplex chronicus, and then a variety of names that go with VIN. However, the nomenclature changed in 2006, and your pathologist may be a part of this now, in Washington, where what they do instead is basically they say if you can look at a skin lesion and you know what it is, you just call it that and that's its diagnosis. If you're not sure, do a biopsy. If the pathologist knows what it is, then she or he will tell you what the diagnosis is. But if the pathologist themselves doesn't know what the diagnosis is, depending on how it looks, they will give you a differential diagnosis. So you may start seeing pathology reports that look like this. So the main kinds of vulvar dermatoses that you'll see are lichen sclerosis, which occurs in about 2% of women in GYN practice. It's due to autoimmune changes. We see it mainly in older postmenopausal women. The take-home message about LS is that once you've got it for the rest of your life, and you'll need to be treated for the rest of your life. It can progress to VIN, and a woman who has it is at a slightly higher risk of developing squamous cell cancer. So I'll skip over the symptoms and find what I mostly want to do is to show you what it looks like. So there are two variants that you'll see of lichen sclerosis. One is that women start to have a change in their vulvar architecture. So you see in this particular patient, she's lost part of her labia majora, and over time, this will only get worse. The other thing that you see is a thinning of the vulvar skin to what's called cigarette paper or parchment paper epithelium, which is very sensitive to touch and to sitting for long periods of time and is very, very itchy. And then when a woman's had lichen sclerosis for decades, her vulva may look like this, where she's had a gluttonation or loss of her clitoral hood, loss of her labia minora, narrowing of her introitus, and this parchment paper appearance of her vulvar epithelium. So we always biopsy in premenopausal women, in postmenopausal women only if you're not sure what it is, and I'm going to finish just by telling you about its preferred treatment, and then the rest of the conditions you can read about in the handout. So we abandoned testosterone long ago as a way of treating lichen sclerosis. Nowadays we use a super potent steroid, which is called clobetasol, initially applied daily for 4 weeks, and then stretched out to a to a maintenance dose after that. Okay, and then other things you'll find about treatment are just to remind the woman about the fact that it's chronic, that she'll need lifelong therapy, and I've also recommended for you some ways of getting the itching under control. So with that, I'm going to go ahead and stop, just so we can stay on time. And in the handout, you'll see some additional photographs of lichen simplex chronicus, and then a few pictures of him as well. But with that, I'll quit, and let's go ahead and ask a few questions. Yes?
Michael Pollock's book stated that bacterial vaginosis was found much more commonly in women with low vitamin D, which would go along with the African American population. In clinical practice, I'm finding that it dramatically reduces the BV. I don't know if that's true, but it works.
Yeah, vitamin D supplementation? So you're saying that if women...
3,000 a day of vitamin D.
Okay. I'll look for that in the literature. Thanks for the recommendation. Yes?
You know that classic boric acid has been used for vaginal infection for over the years. Do you have any opinions on this product? And you see we didn't have that listed for BV.
Right. So where most of the evidence exists for boric acid is in the use of women who have recurrent vaginal candidiasis. It can be used for BV. It's not listed as part of the CDC estrogen treatment guidelines. But particularly in the case of vulvovaginal candidiasis, that doesn't seem to be responding to other things, or when women have problems using the needle drug, it is a good choice in that circumstance. But you have to use it very much the way that the instructions are described in the CDC guidelines to avoid boric acid toxicity, which has been reported. Yes?
You didn't really cover this, but I know there's been a name change with VIN as well.